Okay, now we'll do some other muscles of the shoulder, and we'll start with the pectoralis major muscle. Now again, this is not a muscle that's commonly done. If you're suspecting a brachial plexopathy at the cord level, this can be a good muscle to check. It's a large muscle, so it's pretty easy to palpate, but it also, your angle has to be different because the pectoralis major is overlying the intercostal spaces. So when you're putting the needle in the muscle, again, you're not going deep down in because then you'll penetrate through the intercostal spaces. So what you're going to do for the pectoralis major, you're going to insert the needle this way. So you're going to insert the needle going alongside the muscle, so you're kind of piercing it that way. So you're not going, the only thing you're going to touch is more muscle. So when you insert the needle, just keep it on a straight kind of angle going in this way, and you'll left be just within the muscle. Now, just notice I'm using two black electrodes. It doesn't matter what color they are. Just for demonstration purposes, I'm just using two blacks, but this will be the ground and the reference. So that would be there. So I wiped the alcohol clean already, and I have my machine set up for pectoralis major, but it's the same procedure. So I can ask them to do the motion. So the motion will be just bringing your arm up. So it's going to flex the shoulder. So bring your arm up above you. Good. I can feel the muscle popping up right there, and relax. Bring your arm up again. And I feel it's flexing the shoulder and relax. So there's the muscle there. If you couldn't feel that, you can have them horizontal adduct to go into crossing the body, and I can feel also the muscle popping in there. So there's where the muscle, that's where the action of that muscle. Okay, so I have my machine on, sound is ready, amplifier is off. Okay, nice and relaxed, so here we go. So again, inserting the needle in almost horizontally. Okay, nice and relaxed, here we go. Feel okay? Mm-hmm. Okay, now you can just check it, bring your arm up. Okay, not quite, so I go a little bit more. Go a touch deeper. There we go. Push up. Now I'm in muscle. So I had to just go a little bit deeper, and now I'm in the muscle. So I can hear that muscle popping up there, very good. So that's one, so relax it. Okay, so that's one location. So I'm gonna go a little bit. One quadrant, good, relax. One depth, two depths, relax, 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 good. There's another depth, good. Extract it, doing okay. One, two, three, good. Extract it, redirect. One, two, three. So there's my three depths in four quadrants. Nice normal as was before. I can stop the buffer, store the live buffer. There it's stored. Make it back to live again. Increase my gain to 200. Doing okay? Mm-hmm. Okay, now very gently bring your arm up. Good, there's some nice motor units of that muscle. Good. Go a little bit more. So you're seeing a few different more motor units. Again, all normal amplitude, duration, and shape. And relax it, good. Extract, redirect. I'm in muscle, good. Push up a little bit. Not quite, so I gotta move around a little bit. Doing okay? There we go. Push up. There we go. There's the muscle there. So, and obviously also notice my placement of my other hand. So my placement of my other hand, this would also be safe, but I would also ask permission first for testing with a female. Even though I'm nowhere near the breast tissue, you want to be far away and be safe. So my other hand is palpating it like this. So with the female, you obviously ask their permission before doing this muscle, and only when it's indicated. But I'm resting my other hand up high enough to avoid their breast tissue area. So that will be that muscle there. So there's some motor units. So now I can store the live buffer and stop it there. Now this one's a big muscle, so you may not get to see good recruitment on this. So I'm gonna go back to live and now go to 500. And this muscle is probably gonna overpower me. So very gently push your arm up. Good. There's some motor units there. And go a little stronger. And we're getting some more motor units. Good. And go a little stronger. And a little more. And a little more. And a little more. And relax. And good. And we got some nice, good recruitment there. So I turn the machine off, stop the buffer, and store the live buffer. So that's the pectoralis major. So again, a good muscle to check for suspected brachial plexopathy off of the cords. Got a little blood there, so we're going to put a little tissue here, a little gauze pad. And again, you noticed I didn't go, when I put the needle in, I tried to stay as superficial as possible. I went just a tiny bit deeper, but definitely not down this way, because that would go in towards the lung tissue. So you want to make sure that you're always angling the needle towards the sternum. You're pointing it towards the sternum, staying as superficial as possible to avoid penetrating deep. And I used a very thin needle. Didn't take too much muscle activation to get it. It's a nice, good, easy muscle to check. So that's pectoralis major. So put a little pressure here. Good. Put a little more pressure. So next muscle we're going to do, the buffer is stored, is we're going to do the supraspinatus and the infraspinatus, both the rotator cuff muscles. So the bleeding stops, so we can take this off here. So now I can ask the patient to turn and lay onto his left side, please. Okay, that's good. Okay. So the infraspinatus, supraspinatus, again, these are very good for shoulder pathology and for brachial plexopathy, because these are coming right off of the plexus and not coming from the plexus, not going to the cords. They're coming right off the trunks. So this the supraspinatus, infraspinatus of the suprascapular nerve, coming right off of the upper trunk, and also innervated by C5 and C6. So place the alcohol wipe right over here, and there under the supraspinatus. So we got the alcohol clean the area. Now the motion is going to be external rotation. So we ask the person to bring their arm to the side, and the motion is going to be just bringing their arm off the shoulder, so off their belly. So they're going to lift their arm off their belly and turning their arm out that way. So full external rotation. And our border is going to be the spine of the scapula. So we find the spine of the scapula, so there it is. So anything above that is going to be supraspinatus. Anything below that is going to be infraspinatus. Now with the supraspinatus, the trapezius muscle is overlaying the supraspinatus. So we're going to have to push in through the trapezius in order to get to the supraspinatus. So the way you can feel that, again, the trapezius muscle will cause shoulder elevation, cause scapular elevation. So we know that we're in the supraspinatus is when the person externally rotates, you'll kind of feel the scapula. You'll feel the bone of the scapula, and you just back the needle off of it a little bit there. So you ask the person to do rotation of the shoulder, and that will allow you to get to the supraspinatus. So I have my machine set up. I'm going to take my needle. There's spine of scapula right there. Place the needle in, nice and relaxed. Here we go. Needle's in. Going to insert it, and there's the spine of scapula. I ran out of room, so then there's the shoulder blade, the scapula. So I extract it out. Now I'm in the supraspinatus, and he's rotating it ready. So relax it, relax it. Relax, relax, relax. There we go. Good. He was shrugging his shoulder a little bit, so now we got some elevation, so now he's relaxed. So now I'm in the supraspinatus. Relax, relax. Good. One. Relax, relax, relax. Bring your arm back up on your belly. Bend your elbow. Good. Hold it nice and tight like that. So hold your arm in like that. Good. So I'm going to give him a little pressure, a little bit of approximation. Relax, relax. Relax, relax, relax. Push your arm into, there we go, good. Push your arm into your belly, just like that, good. There's 1, 2, 3, good. Extract it and redirect. There's the scapula, come out a little bit. Good. 1, 2, 3. Extract. Redirect. 1, 2, 3. Good. Doing okay? 1. Relax. Good. 2, 3. Good. So there's my resting assessment. So I'll stop the live buffer and store it. Okay, go back to live again. Go to 200. Okay, so now that should be easy. So now turn your arm out to the side, off your belly. There's some good motor units. Okay, there's another one. There's another motor unit. That's good. I move the needle slightly and get a different motor unit. Very good. I can extract it and redirect it. Push out, lift off your belly. Good. There's another motor unit there. Keep pushing. Good. There's another motor unit there. Nice, loud, crisp, normal amplitude, normal shape, normal duration, normal firing rate, not going too fast, not seeing more than one of those on the screen at a time. Okay, relax it. Good, relax. So I stop it, store live buffer. Good. Go back to live again. Now we'll go up to 500. Okay, so very gently, turn your arm out to the side. Good. Now go a little stronger. Go a little more. So we're getting some more motor units. Go a little more. Good. Get some more. Go a little more, a little stronger. Get some more motor units. A little more. And relax. Good. So we're getting decent contraction, so that was good. So I can turn it, press stop on the screen, and store live buffer. So that was supraspinatus. Take the needle out. Place the little gauze on top there. Now infraspinatus, the same thing. We're just going a little bit distal. Now usually you would only do both if you suspected a lesion of the suprascapular nerve in the spinal glenoid notch, because that would be the only time an isolated lesion of the suprascapular nerve, if it's in the plexus or if it's in the C5 root level, it would affect both levels equally. But something that affects the supraspinatus but not the infraspinatus, that would be when you would suspect of one being abnormal and not the other. So usually, unless you suspect specific rotator cuff pathology, where the nerve is entrapped after it innervates this supraspinatus, but before the infraspinatus, then you would check both. Otherwise, checking one or the other is okay. But for the infraspinatus, it's the same exact motion. So we're going to go to infraspinatus, back down to 100. So now we're below the spine of the scapula. So now we're below it here, and the motion is going to be the same. So there's the medial border of scapula. So there's the body of the scapula right there. Okay, this one you don't have to go too deep because the trapezius doesn't cover it as much. So we're only going to come in a little bit. So nice and relaxed. Here we go. Motion is going to be the same. Feel okay? Yeah. There's the scapula, so I can back off a little bit. Okay. So there's no other muscle there. If you just wanted to double check, turn your arm out to the side, and right away there's some nice motor units. So I'm definitely in the infraspinatus muscle. I know I was in it because I pushed in and hit the scapular border, hit the scapula itself, so you just back off and move away. So same procedure, 1 depth, 2 depths, 3 depths, extract it out, 1 depth, 2 depths, 3 depths, extract it out, 1 depth, 2 depths, 3 depths, extract it out, 1 depth, 2 depths, 3 depths. So there's my 3 quadrants, 4 quadrants, 3 depths. I will stop the screen and store the live buffer. Good, that's stored. Go back to live again. Go to 200 on the gain. Okay, very gently, turn your arm out to the side. There's some nice motor units. So a little bit less. Good. Very good motor units there. Go to a different area. There's some more motor units. Again, looking each individual motor unit, looking at the shape. Hold that right there. Keep looking at the shape, the amplitude, and the duration. Good. Good, very good. Okay, relax it. Okay, just redirect to a different location. Okay, good. Again, checking the motor units, normal amplitude, normal duration, normal shape. All very good. Nice normal. Okay, relax it, relax. So let's pretend that was 12. I stop the buffer and I store it. Good. Now I go back to live again. Go to 500. Now very gently turn the arm out to the side. Good. Now go a tiny bit stronger. Good, a little more. A little more. A little more. A little more, a little more. Push, push, push. Push, 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 push. Doing okay? Doing okay? Make it a little stronger. There we go. That's it. A little more. Good. We got decent recruitment and this decent interference pattern there. So I stop it. Stop the screen. Take the needle. Needle's out. No blood. If there was, I would have put a little pressure, but there isn't. So I now store the live buffer, and I have the 3 different buffers for the infraspinatus. All right, so now I'm going to switch positions a little bit, and we're going to do some muscles of the leg. Okay, next we're going to do semimembranosus. So semimembranosus, you can do it either in prone or in side lying. So we're going to do it, it's very similar to the bicep femoris, but now we're on the medial side of the leg. So we're going to wipe alcohol, we're going to go to the medial aspect of the knee, but the motion is going to be the same, asking the patient to flex their knee. So the semimembranosus, again, not commonly done, but it is optional. Possible if you suspect a L5-S1 radiculopathy, so we can check it there. The action is going to be bending or flexing of the knee, so let's have you bend your knee, and I can feel that muscle tendon popping up right there. So nice and large, very good, and relax. So again, I'm going to insert the needle in, going in proximally. Let the area dry for a second. We're at 100 on our gain. Take the needle out and insert the needle in, nice and relaxed. Here we go, 1, 2, 3. Good, needle's in. Okay. Okay, needle's in, so I heard the discharge. There's 1 depth, 2 depths. Let's see my hand. 3 depths, good. Extract it out, redirect. 1, 2, 3. Extract out, redirect. 1, 2, give it a second. 3, good. No sustained activity. 1, 2, 3, good. That's 3 quadrants, 4 depths. Pause the screen, store the live buffer. Good, stored. Go back to live again. Go to 200. Now, just as before, just very little motion, we'll be able to activate this muscle. So bend your knee. Good. There's some nice motor units there. Again, it's a normal amplitude, normal duration, and normal shape. Good. Keep holding it like that. Just hold it. Move the needle slightly. Good. And there's 1 polyphasic in there. That larger one in the middle is a polyphasic waveform. That's good. Go to a different area. Normal amplitude, normal duration, normal shape. Again, a little dull, so I'm going to move that needle a little bit to a different location. Relax, relax. Okay, change my angle. Now I'm picking up new motor units. So I'm picking up new motor units. Those are all normal, normal shape, normal amplitude, normal duration. Keep pushing. Good. Okay, relax. So let's pretend that was 12. So I stop the buffer, store the live buffer. Good. Now I'll go to live again. Go to 500 on my gain. Okay, very gently. Try to bend your knee. Good. And go a little stronger. Looking at the recruitment, seeing that there's more motor units activated as he contracts harder. Go a little stronger. Push a little more. And a little more. And a little more. A little more. And relax, relax. Good. So that was good activation. Pause the buffer and store it. So that's the semi-membranosus. Okay. Take out the needle. Check for blood. There's no blood, so that's good. Now we're going to go to, actually there's a little bit of blood, so I'll put a little pressure here. Okay, next we're going to go to the gluteus maximus. So the gluteus maximus is useful if you suspect an S1 injury, and that is another muscle. Most of the S1 muscles are innervated by tibial nerve, but the glute maximus is obviously the gluteal nerve, the inferior gluteal with the TFL and glute medius on being superior gluteal. So glute max is a good S1 muscle. So the pressure is good there. So we're going to now just move these up a little bit and come up here. Okay, so glute max will be similar to around for the paraspinals, and we don't need to see the, I'll save jokes for later, but we don't need to see the whole show. We're just going to bring this down just a little bit, and coming in right kind of center, very proximal, is going to be the glute max. So the glute max is large up in the upper area, so we'll leave it right there. The motion for the glute max is going to be extension of the hip. So I'll just ask the patient to gently extend the hip, kick back towards me, kick back, and I can feel the muscle underneath my thumb right there. That's good, that's good. I can feel the muscle underneath my thumb right there, so that's where I'm going to insert the needle. So I'm going to insert the needle right there. Just going to get the alcohol right in there. Good. Okay, go to my screen, select glute max. Turn the amplifier off, good. All right. So I take the needle, nice and relaxed, here we go. Feel okay?
Yeah.
Does it burn a little bit?
Oh no.
Okay. Okay, now I need to get into the muscle. So there's the muscle. I'm in muscle tissue there. I heard the discharge. Bend your leg back, push back, there we go. Good, we got some nice hip extension. So we got good activation of the muscle. Good, and relax, good. So we're in muscle, so we're in the right location. And we're not in that deep. Again, there's the iliac crest up here with this finger. So again, we're not going too caudal. We're keeping the patient modesty intact. So we're still very good. So now we can just do our assessment. So there's one depth, there's second depth, there's third depth. Extract the needle out, redirect. One depth, two depths, three depths, good. Extract it out, redirect. One depth, two depths, three depths, good. Go to our last quadrant, extract out, and redirect. One depth, two depths, three depths. So there's our three quadrants, four depths. Under glute max, pause the buffer, and now we store it. Good. Go back to live again. Go to 200. So I'm at 200. Now I brace the patient. Gonna ask them to gently bring your leg back, kick back towards me. So there's some nice motor units there. Again, looking at the amplitude, the shape, and the duration. Those are nice and normal. That one has a few turns in that one, but still normal. Turns are okay. It's when turns are, again, when it doesn't cross the baseline. When those are not crossing the baseline, they're getting close, but not crossing, so those are normal. Good. Normal motor units there, good. Go a little deeper. Some patients with more profound gluteus maximus, you may need to use the 3-inch needle, but this is 2 inches is fine. Good, some nice motor units there. Okay, relax. Okay, I'm just going to redirect it to get different motor units. Extract the needle out, subcutaneous, redirect it. Okay, good, there's motor units. Push back a little bit. Good, a little less, a little less. Good. There's some nice perfect motor units there. Very good. Okay, so let's pretend that's 12 and relax, relax. Stop the buffer, store it. Good, now go back to live again. Go up to 500. Now you're probably not going to have enough resistance in yourself as the examiner to resist it, but try to push back. Good. And a little stronger. And a little more. And a little more. And a little more. Again, these low strain muscles are hard to get good activation. And a little more. And good resistance. A little more. And that's probably the best as we're going to get. And relax. So again, the glute max muscle, again, is going to be a little bit difficult to get full interference, textbook full interference, but it's normal enough for that assessment. Got a little blood, so I have a little thing here. I pause the screen and store the live buffer. So there's the gluteus maximus. And then finally, we'll do 2 other muscles in the thigh on the anterior surface. So we're going to do the rectus femoris and the TFL, tensor fasciae lata. So now, if I can ask my patient to bring this up a little bit, if I can lay onto your back, please, face up. Okay, that's good, that's fine. All right, so let's do the easier one first, as far as getting the muscle, the rectus femoris. So again, rectus femoris is another L4 muscle. This one, again, only if you suspect an L4 injury or an isolated femoral nerve injury. Usually the vastus medialis is good. The adductor is another good L4. Anterior tibialis has L4. Rectus femoris is L4. It's hard to get a good contraction because we're going to have to resist hip flexion as well. But it's another L4 muscle and another femoral muscle that you could possibly check to check for there. So rectus femoris, right in the center of the leg, right in there. So I'm going to select rectus femoris. There we go. All right, let the alcohol dry. So this motion, straight extension of the knee, is not really going to cut it too much because it's a 2-joint muscle. So you're going to have to really resist the patient and have them flex their hip as well. So you're going to have them actually bend their hip up this way to resist that motion. So you're going to have to put a lot of pressure as far as getting good resistance to get that good motor unit there. So right in the center of the thigh, where we're going to place it. Okay. So there's the needle. Make the skin nice and taut and relax. Here we go. Needle's in. Okay, bring your leg up, your whole leg up in the air. There we go. Good, and relax. Good, and relax. So you're almost doing a straight leg raise where the person's going to lift their leg off the table. And now relax. Good. So now he's relaxed. Now it's the same as procedure. 1 depth, 2 depths, 3 depths. Good. Extract out. Redirect. 1 depth, 2 depths, 3 depths. Extract out. Redirect. 1 depth, 2 depths, 3 depths. Good. Pausing a second or 2 between each one. Extract out. Redirect. Last time. 1, 2, 3. So that's 3 quadrants, 4 depths. Stop it. Store live buffer. Go back to live again. Okay, now I'm going to push my gain to 200. So I'm going to resist a straight leg raise. So bring your whole leg up off the table. Good. Too much, just a little bit. Good, perfect. Just like that. It was a little bit rounded, so I'm going to try to get a little closer to it. Good, there we go. A little on the larger side, but still nothing out of the ordinary. Again, nice and large, good. There we go. And all still normal. Good, and relax it, relax. Let's redirect it, find some more motor units. Again, looking for 12. You okay? Okay, bring your whole leg up, push up. Good, too much, too much, too much. Good, very good. Again, those are maybe a little bit too big, so let's actually change our gain to 300. Keep holding it. So let's change my gain to 300, so I can now see the whole of them, and I can see that they're not going that large. So it looked like at 200 they were a little bit too big, but now when I change it to 300, if I wanted to stop the screen, let's stop it and relax. Stopped it for a second, and we're going to look at those motor units, and we can see that the size of this one here, 3, 6, 9, 12, 1500 motor units. The way you can also do that, I counted the boxes, but are you okay with the needle there? Mm-hmm. Okay, you can also, if you click on, right click, and you can put on amplitude markers. So if you right click it, and you can do this when it's stored as well, if you go to amplitude markers, click on that, and now you can drag them up, see where this up says up here, where the number is, you bring this down this way, and now you drag this up here, and now that gives you the exact amplitude, so 1,576 microvolts. So that's how you, and if you wanted to store that, take a snapshot, you can take a snapshot of there, and that gives you that amplitude, that waveform of that amplitude. So that is that. So let's store that buffer file as well. Okay, and move this a little bit. It actually came out of place, so let's move that back there. That's where it was. Good, 15. There's our motor unit amplitude. Okay, now we can go back to live again and take those amplitude markers off. So I'm going to right click again and turn them off. Okay, now go to 500 and go to 500 and gently bring your leg up. Push your leg up a little bit, good. And now go a little stronger. And go a little more. And a little more. A little more. A little more, a little more, a little more. And relax, good, that's good enough. So now we can stop it. Store live buffer, stop the buffer, and store the live buffer. So now we have our rectus femoris. We take the needle out. Good, feel okay? All right, put a little pressure there. Next one, we're going to do the TFL, or tension fascia lata. So for this one is going to be up in the anterior hip area. So we're going to come and we're going to palpate on the side of the leg. We're going to feel for the greater trochanter. You can feel the greater trochanter by asking the person, the patient, to turn their foot inwards. And as they turn their foot in, you feel that bone on the outside of the leg, that's the greater trochanter. So we're going to come and we're going to insert the needle medial to that. So we're going to insert the needle medial to, just medial to the greater trochanter. So we're going to just bring the pant down just a little bit. And we're going to come to the TFL, which will be right over here. Here's the greater trochanter. Here's the iliac crest. We're going to come in between them over here. So I'm going to take the needle, move this over here, go to my screen, select TFL on the screen. I'll move my electrodes are good over there. So I'll take my alcohol wipe, place the alcohol wipe here. I'm going to let that dry for a second. So again, the TFL, the motion for the TFL is going to be rotation inward. So we're going to ask the person to just turn their leg in, and that muscle will pop up right there nice and big and relax. Good. So there's the TFL muscle right there. Okay. Take the needle. Okay, nice and relaxed. Here we go. There's the needle. Needle's in. Turn it in, turn it on, and turn your foot in. Okay, we're not in yet, so relax. There we go. He's turning his foot in, and we're seeing nice motor units. So we're seeing nice motor units. He's turned his foot in, so we're in the muscle. So relax. Relax, relax, relax. Relax, relax, relax. Turn your foot out to the side. There we go, now he's relaxed. Sometimes TFL can be a little bit hard to relax, but now he's totally relaxed. There we go, good. Okay, so now we can move through our insertions. 1, 2, 3, very good. Extract out, redirect. 1, 2, relax, relax. Good, those are motor units. Good, now he's relaxed. Good. Extract out. Good. 1, 2, 3, relax, relax. Good. I know those are motor units because after he relaxed, it goes away. Now I can go back to, I'll store that buffer. So I hit stop and store that buffer file. Okay, buffer file stored. Go to live, go to 200. Okay, now he's already turning in, which is good. Looking at those motor units. Nice normal amplitude, normal shape, normal duration. Very good. Move the needle a little bit. There's a different motor unit. Couple different ones there. Again, normal amplitude, normal shape, normal duration. I'm resisting with my other hand down here on internal rotation of the hip. Good. I'm going to extract it, redirect. Come back a little bit this way. Doing okay? There we go, now we're in. Okay, keep turning, turn the foot in, good. Some nice motor units there. A little bit less, go a tiny bit less. Good, perfect, very good. Normal amplitude, normal shape, normal duration. Good, I'll just go just a tiny bit deeper. Good. And we got one polyphasic one there. Turn a little bit. Nope, went away. Didn't sustain it, so it must have been a different phase. So that's good. But still, it would have only been one abnormal one, but that's not significant. Okay, so let's pretend that would be 12. So now I'll stop it. Stop the buffer, store it. Buffer is stored. Go back to live. Now go to 500. Go to 500. Now turn your leg in, turn your foot in. Good. Now a little stronger. Yeah, a little more. A little more. Again, these leg muscles are hard to get good textbook interference. Go a little more. A little more. A little more. And relax. Good. Rest. Good. So again, relatively good, normal, relatively full interference. Stop it and store the buffer. Buffer stored. Take out the needle. If there's a little blood, just a tiny little bit, take a little gauze, place it in the area, and that muscle is finished. So that is the some more proximal muscles of the hip and the shoulder area. Thank you.